Well, hi, I'm Felipe Botero-Rodriguez from Colombia. I will tell you about our experience there. First, Bogota is the capital of my country, and there is in a valley. So here you can see Bogota. The next one here is our university, Javeriana University, and this is part of the team. Our city have a particularity, yes, the population. It has 7.8 million persons that it implies people, and it implies the 15% of the population of Colombia. Considering this, we have only one psychiatry per 100,000 people in our country. And all those psychiatrists are ubicated or localized on only well, most of the psychiatrists only on 5 cities on our country, considering that we have more or less 1,300 municipalities. Also, the communication between clinicians, patients, families is often challenging. It may be because of the heavy emotional burden of clinicians, patients, but also the emotional burden of the families of the caretakers. And I think that in medicine is in that way, not only in psychiatry. We can find that the relationship could be hierarchical. So it can be difficult for all the patients, all the participants. Now, the multifamily groups, it has been tested in different countries. It is based on a trial, and it have some rules or some characteristics, like groups are composed by clinicians, patients, and their families or friends. It recognizes the civil rights, the patients and the family strength. It must be a mutual respect, and it should be a safe space for sharing experiences and for a mutual learning. Also, it is flexible, allowing for a local adaptation. Well, our implementation, we made 6 groups. Each group should meet monthly for a time of 6 months. And each session or each meeting should long from 70 to 19 minutes. They had or we gave them some refreshments and the travel expenses to facilitate the experience. It is important that to say that we could make all the sessions despite the difficulty on attendance. It means the traffic in Bogota is very difficult, mainly Saturday and Fridays that were the days that we used for these meetings. And for other characteristics. And previously, in each meeting, they talked about previously established topics that families and clinicians thought that were very important to talk. Well, in our quantitative results, we enrolled 30 patients, 15 female and 15 male, most of them with bipolar disorder, the blue one, and the age range was from 24 years old and 61 to 61 years old. Yep. About the family or friends, we enrolled 41 participants. Most of them were female, and we got 7 male. And the age range was broader from 24 to 85 years old. About our results or the outcomes, we saw or we found a improvement in all outcomes. That if you see, you can see that it's not statistically significant, but it maybe was for the small sample. Nevertheless, you can see a very a positive trend and an improvement of these means. Also, this intervention, family intervention, was already tested in another studies. So here our main aim was to test the feasibility of this intervention in our country. Okay, about the qualitative part, we interviewed 6 clinicians, 15 patients, and 10 family or friends. We got, we got 4 main domains. First, the non-hierarchical relationships. We found a change here, and you can see in the code, the experience was pleasant because in some way you feel like the others. It was a space more comfortable for all participants, and it gave the opportunity to talk about many doubts, many topics that maybe in the normal consultation, patients don't used to talk about it. Another one is the collaboration between the participants, not only the patients, but the participants. You can see it helped me feel supported, listening to the more of the other patients I identified with their experiences. It was very important to let them know that they are not alone. And that maybe is a thinking that patients, but mostly familiars of the patients that could have in their heads. Yeah. Another one is solutions in everyday life. Here is a point that cover different topics. For one side, in one hand, we found some practical things that we have to think when we are going to apply it in Colombia and another study. Yeah, but also it includes some topics like legal concerns and medication doubts. And finally, changes in the we found changes in family dynamics. It is because families sometimes get out of the dynamic of the consultation. Now, our conclusions: multifamily groups are feasible and low cost. They can be beneficial for patients and their families. Also, they are an option to improve community mental health care approaches. However, we have to take into account practical aspects of implementation that are very important to facilitate attendance. And lastly, longer provision need to be tested in Colombia and in other countries, I think.